Queridos amigos, muchas gracias, Federico, mi grande amigo, por tu invitación. Disculpe mi español, solamente unas palabras por agradecer a Federico y hacer un saludo a todos los amigos en España. Y voy a presentar mi charla en inglés. Okay, so the topic I'm going to talk to you is going to be some hits on advanced imaging in congenital heart disease evaluation for both pre-surgery or for particularly catheter interventions for a variety of congenital heart defects. First of all, I'd like to introduce immediately the technique that we started to use approximately 4 years ago, the 3D rotational angiography. It means that this technique was developed some years ago, but became, let's say, very popular only recently, 3 or 4 years ago. And is a very innovative and sophisticated technique in the cardiac catheterization lab, particularly for complex cases. Well, this is the protocol we had from Gregor Krings from Utrecht. The concept of 3D rotational angiography is to inject contrast that is going to stay enough time in the chambers of the vessel we want to visualize in order to allow us to do the 3D reconstruction of the picture we have taken. We can use diluted contrast medium, about 60% diluted. We calculate about the body weight, etc. I don't want to go into details about that, but very briefly, the technique is to have the patient intubated and ventilated. We stop ventilation 1 or 2 seconds afterwards. We start rapid pacing in order to reduce the cardiac output, and we inject. And the injection will last approximately 6 seconds, which is enough to fill the chambers of the vessel we want to visualize. This is an example of the aortic pressure that is going down with rapid pacing. And this is an example how the X-ray tube is rotating after starting the rapid pacing. The 6 seconds rapid pacing, we can use it in both Philips and Siemens machine in our institution. And this is an example of a complex with MATCAs, many collaterals. And in a few seconds, or few minutes, I would say, we can have a beautiful 3D reconstruction of very complex vessels in order to be able to, particularly to show the surgeons in this particular case where the vessels are, where are arising off, and to plan the most proper surgical repair. Well, what are the indications for doing 3D rotational angiography? Briefly, the complex arch problem, pulmonary branch stenosis, or some catheter interventions like a pulmonary valve replacement or coronary artery disease, partial cavopulmonary connections, etc. And the traditional angiography, you have a single plane with a single injection. There is no need of ventilation, rapid pacing, contrast dilution, etc. But the advantages of 3D rotational angiography that with a single injection we can acquire multiple views of the anatomy. And this is a very useful guide to carry on with catheter manipulation to do diagnostic or interventional procedure. And as far as the X-ray dose is concerned, you may argue that with prolonged injection, we are giving more X-ray dose to the patient, but it has been demonstrated that there is no significant difference of X-ray to the conventional biplane angiography and 3D rotational angiography. This is our first year experience for March 2015-2016 doing rotational angiography, more or less 100 patients. You see the diagnostic catheterization we did, particularly pulmonary atresia, VSD, and MAPCAS on or univentricular heart with Glenn anastomosis, etc. And interventional procedures like particularly pulmonary valve implantation, coarctations, and stent in pulmonary branches. And the doses we have given to the patient is not as high as the biplane angiogram. This is an example of a diagnostic case of a complex pulmonary atresia, VSD, and MAPCAS. As you see, you can separate and fuse the picture. You see the aorta, pulmonary branches. You can see separately of overlapping, and you get in few minutes a very detailed idea of the anatomy, which is very complex, of course. And this is another example of a very complex 4-year-old baby with complex defect with Demus K stancil anastomosis and Glenn. You see the overlapping of the pulmonary artery and branches. You can navigate through the vessel lumen as well. You can fuse, overlay the pictures of the aorta. And in addition, you can also see, this is a unique feature obtained only by 3D rotational angiography. You can also see the airway, that sometimes is important for potential, for example, compression of bronchi by stenting, for example. Well, this is another example of a hypoplastic left heart with, after palliation with bending on a main PA and bending of the both branches. You see the overlay of the aorta, the single ventricle, pulmonary branches, etc. And this is another example of a complex cord with aneurysm, as you see here. You can select the best projection to use during catheter intervention. And by using this, you have the so-called iPilot, or you can the overimpression and overlay of the previously pictures taken by 3D rotational angiography and real-time fluoroscopy. So they sometimes it's not possible to have a perfect overlay because the stiff wire can change a bit the orientation of the vessel. So you have to take into account this. Well, this is an example of this complex cord with aneurysm. In this particular case, we used the technique of single stent mounted on 2 balloons with simultaneous implantation of the stent by avoiding the occlusion of the side branch vessels, because you can fix exactly when you want to see. And this is the 3D rotational angiography and 3D reconstruction immediately after stent implantation in this particular case. Well, pulmonary valve replacement is another case where we started 3 years ago. We do routinely 3D rotational angiography in the cath lab. This is an example of a previously done Ross procedure with degenerated RV2PA conduit. And this is the conventional angiography in this case, and the 3D rotational and 3D reconstruction. And you see here the aortic root with a single injection in the aortic root with rapid pacing and 3D. You can see very, very clearly the origin and the proximal course of both corollaries. And when you do balloon interrogation to avoid the risk of coronary compression, you can clearly see the distances between the balloon inflated in the RV outflow tract and the origin on the corollary. So instead of doing multiple injections in both corollaries. Well, this is the case with afterwards conventional angiography, another technique with a single stent, double balloon, with the 2 wires in both branches, gradual inflation of the distal portion of the stent to avoid the migration and be sure about the stability of the stent. And as you see here, afterwards we implanted a melody valve in this particular case, and then you can appreciate the nice evaluation of the position of the stent. And another example of aortogram or a selective coronary in relationship with the balloon inflated in the RV outflow trial. You can appreciate very, very nicely the spatial relationship between the balloon RV outflow trial and the coronaries. And this is the annulus of the previously implanted surgical bioprosthesis. And so the balloon test is very, very easy. So this technique can provide important additional information, and possibly we are going to reduce the X-ray dosage as well. Another technique, a fusion imaging technique we're using, is to previous doing MRI, CT, or both in the same patient, and afterwards, by using the software called Heart Navigator, we can segment the different cardiac chambers or vessels which are superimposed with the real-time fluoro, and it's going to be a useful guide to see where the wires and catheters are going. You can have the overlay of the aorta, for example, as shown here. You can fuse, you can take it out, you can focus on the chambers you want to see better. And guiding stent implantation is also useful. You see in the conventional angiography, but at the same time, with overlay of the previously acquired picture from CT, you see the chambers. In green, you have the right ventricle. In violet, you see the main PA. In red, the aorta. And you see the stent expansion and the valve implantation in that position. Well, changing the topic of the subject, going towards the atrial septal defects, for example, a major advance achieved some years ago from 2D to 3D reconstruction of the anatomy of atrial septal. This is a 2D, you see a double defect in this particular case, and very well visualized with 3D reconstruction. And since 1 year, we are using another software during interventional procedure of ASD closure, which is Echo Navigator. With this software, we synchronize the TOE probe with the fluoro, so you can have the simultaneous overlay of the fluoro pictures and echo pictures. And in some cases, like in this double defect, you clearly see the two wires and two balloons going into both defects, and we are quite sure that we are in the correct spot. And so we can evaluate the size and the position of the defect, and in this particular case, to implant two simultaneous devices. As you see here, the small device implanted first, the larger one overlaying or overlapping the previous one. And by only echo, you don't see what's going on. And by fluoro as well, you don't see exactly what's going on. And with this technique, we can be more sure about the correct position of the two devices, as you see here in 2D and 3D reconstruction immediately after stent implantation. So the multimodality imaging in the cath lab proved to be very, very useful. This is an example of the large screen we are using in the cath lab, and this is an example of what you can see simultaneously. You can see the conventional fluoroscopy, the pressure tracing, the overlay of the fusion from CT, transesophageal echo. You can see everything in a single large screen. And then, according to the peculiarity of each individual case, you can select what you want to see. If you want just to see the echo, for example, we just have a single picture of echo. You can see, if you like, fluoro and echo, etc. So you select what kind of images you want to use during catheter intervention. Well, another topic that I would like to talk to you is the computational simulation of pulmonary valve implantation. That's a work we started some time ago with our friends bioengineers. And this is also very important, starting about the pioneer experience by Silvia Schiavano, Daria Cosentino, etc., to evaluate the simulation of what's going on in a conduit when you want to put a stent. So there are some issues, as you know, possible coronary compression, the issue of calcium interaction with the balloon and stent migration, rupture, etc. So the main objective is develop a finite element models towards a realistic pre-stent simulation before pulmonary valve implantation. So the specific objective is to reconstruct the patient-specific anatomy before bringing the patient to the cath lab. This is our first experience in 5 patients with Ross and tetralogy for pulmonary valve implantation. The flow chart is to have a CT acquisition, particularly focused on the position of the coronaries. Then we do the 3D segmentation by using a commercially available software, well, in our case by Materialize, which a very experienced company who developed since 20 years ago the technique of segmentation and 3D printing as well. And this is the reconstruction of the anatomy, the computational simulation reconstruction of the anatomy starting from CT, as shown here. Then, when you have the modeling, we carry on and study what is going to be the predicted behavior of the tissue when implanting or inflating balloon on implanted stent. Of course, there are the complex formula that bioengineers are using. Don't ask me about this formula. I rely on them because they're very, very serious and competent people. And they study the behavior of stents, the fatigue, and all these characteristics, the mechanical properties, etc. And they can simulate what's going on when inflating a balloon and expanding the stent. This is an example of the simulation of expansion of a big balloon up to the 22 millimeters with the maximum size we can inflate the balloon when implanting the melody valve. So we can simulate the pre-stent finite element analysis, and as you see here, that's the inner expansion of the big balloon, looking at the calcification that you may see in transparency, more in white. Then the outer balloon is expanded. We can evaluate the recoil as well. And this is the predicted behavior of the conduit size before and after stent implantation. You can predict reliably the measurements we are taking in the cath lab. You see here the distances between the RV outflow tract and the coronaries, which is of paramount importance before implanting the stent. And we did some verification, the validation of this simulation, and the measurement we have obtained before and during catheterization were very, very similar. The bioengineers can also evaluate the biomechanical variables of the tissue and the calcium. In this color-coded scale, you see the maximum stress, which is in red, the minimum stress in blue. So that's the predicted movement of the calcium in the conduit when implanting the stent. So the validation of this work is something that we are doing now. All these data are validated in the cath lab when we do 3D rotational angiography in all cases, and we compare the data we acquire before by computational simulation. So this is very important. We want to develop a realistic 3D anatomy before bringing the patient to the cath lab, try to understand what is going to be the behavior of the tissue. But sometimes when you have a lot of calcium, this is not possible 100%. So you have to be aware, we have to be aware about also the limitations of this technique. And possibly we speed up the simulation. When 2 years ago the bioengineers started doing this work, to simulate an expansion of the stent. This process was approximately 1 week, 10 days time to simulate. That's a very long process with the sophisticated computers, but now we are progressing and speed up the simulation very much. And another step forward is to print the 3D model and simulate the procedure in that patient. This is an example of a right ventricular to pulmonary artery conduit dysfunction, candidate for percutaneous pulmonary valve implantation. We acquired from CT the STL file from a materialized model, the 3D model, and we printed with this model. As you see here, we can this is 1-to-1 ratio of the real heart. And you see the conduit, you see the balloon with the stent, which is inserted, and you see the stent implantation, and in white you see the calcification that were present in this particular case. And this is the pictures of conventional angiography in the real patient, and this is the final angiography after Melody implantation. And you see the pictures between the real-time fluoro angiography and the 3D model simulation are very, very similar. And so far, we are very, very happy about the comparison of these two pictures. So we have to thank, of course, the bioengineers and my colleague in pediatric cardiology department for this teamwork, which is very, very important to achieve the best results. Finally, I want to thank you. Muchas gracias, queridos amigos, for inviting me, for tu invitación, Federico, y todos los amigos que puedo ver así. Es para mí un placer y un honor siempre tú estar en España. Muchas gracias.